Hello, Rob, the editor of the Biomedical Scientist magazine here. Welcome to the second instalment of the new podcast series from the IBMS. Each episode of this podcast is based on the Twitter Spaces chats that take place on the first Wednesday of every month. In this episode, we speak to Stuart Dawe-Long about men's health. Stuart is an Andrology Lead at Manchester University NHS Foundation Trust, a clinical scientist and a member of the Cytopathology Advisory Panel for the IBMS. I hope you enjoy the episode, and remember that this can be used for your CPD.
Hello, yes, thank you very much. I hope everyone can hear me out there, and welcome to the IBMS chat tonight. Special thanks to Stuart for joining us. Really appreciate you giving up your evening, Stuart. And yeah, just to reiterate some of the stuff Aisha said, if anyone wants to speak, then please do pop your hand up, and it'd be great to get you involved because we want to make this kind of as much a debate as we can. So if there's anything, then just put your hand up and we'll get you involved in the chat. You can also send tweets using the right handle, and we will pick those up and we'll make sure that we get asking those as well. So, Stuart, if you want to pop your mic on, welcome to the IBMS chat tonight.
Thank you very much. I must say, I'm probably going to go wrong with this at some point. It's the first time I've used the chat, but thank you very much for inviting me.
You've
Hopefully,
made it this far, Stuart. This is the hardest bit. You're over the first hurdle.
Yeah, indeed. With a lot of messages, which I'm quite sure would have irritated a lot of people. But no, yeah, first hurdle over with, and hopefully get some interesting conversation going. So thanks for having me.
Oh, a pleasure. So before we start talking about men's health, Stuart, why don't you fill us in on a bit of your background, how and why you became a biomedical scientist, and how you ended up specialising as you have done?
So it's a little bit of a strange journey, I think, but I don't think it's dissimilar to a lot of people who end up in andrology, which is where my passion for men's health come from. So I actually started training as a within cytopathology, and actually became a senior within cytology, got my specialist diploma, but throughout this was kind of sprinkles of joining in with andrology. So at Birmingham, we had our assisted conception unit, and their embryologists no longer wanted to actually undertake the andrology aspects for diagnostics. And that's when I kind of jumped at the chance when I was but a very, very young, enthusiastic, recently qualified biomedical scientist. And from there, slowly but surely, my passion with andrology started to grow. Now, I think it really took a bit of a hold when I started to get more and more involved with the greater world. So when I started to run clinics where we had patients attending as an outpatient appointment to produce their samples on site, I began to see where we were missing certain things. So I started to plough all of my efforts into not just looking at the diagnostics, but trying to get more involved with gynecology, who looked after fertility, with urology, who really should be looking after men's health. And I slowly started to get a few more people on board to looking at the man in a little bit more detail. And then when you start getting your head in there and running clinics, which is what I ended up doing with men for infertility and sexual dysfunctions, I started to see huge disparities and inequalities, and actually a huge demographic of patients that we weren't really paying attention to, but quite often giving them the blame. So I completely transferred over to andrology. I'm concentrated my efforts on there in Birmingham for nearly 8 years, and only moved to Manchester in January of this year, where I've gained more skills, including cryopreservation and leading the service with some great colleagues of mine. So a little bit of a nutshell review, and hopefully when it comes through this chat, I can bring in bits and pieces that I've experienced and why I've decided to come and support this chat.
Oh, definitely. So we're doing this chat for Men's Health Week. What do you think is the single biggest issue that with regard to your job that men are facing, Stuart?
So I think for me in my role currently, obviously I work in a unit which primarily focuses on infertility of the couple, and also for patients who are storing sperm prior to treatment, which can be for cancer, it can be for surgical reasons due to cancer, it can be benign conditions, it can be going through transgender care. But basically, I think infertility is probably one of the biggest things, and I think it comes from different angles. So at the moment, we've got quite a busy clinic, and I'm sure anybody who runs andrology are never short of patient samples. One of those things, I think, is the fact that they're meant to have an initial sample to be checked, which obviously they should, because you can't do anything with both parts of that story. But also, I think what you end up seeing is the difficulties associated with fertility. So I think first and foremost, and anyone can look up this information. I think WHO published some information a year or two ago, basically saying that 1 in 6 couples are going to face infertility problems worldwide. So I think that's probably one of the biggest things. And then on the back of that, there's a whole heap of involvement, getting the men involved in the process and making them feel like they're part of that journey for that couple, which I think sadly is still very much omitted in most patients facing infertility services.
I mean, we're not known as the most kind of outgoing country in the world when it comes to issues like this. Is infertility kind of? I mean, the statistics you said were very high. Is it a hidden problem, and do you find people are very reticent about coming forward about it?
It's a bit of a strange one. I think there's a perception that a lot of people are quite hesitant and don't want to talk about it. And actually, that's very true in a lot of people's cases. The amount of people who come through and say that, that they want to be happy, their friends have got children, that they're trying to be positive, but behind closed doors, there's a regimented activity going on, whilst also battling with the lack of joy and success in their life, which they put around having a family. And for some couples, it's a huge blow to what they want to achieve. Equally, I've been quite surprised by the amount of men who attend the service, and if you give them the appropriate space, the right amount of room, and you deal with them as a person instead of a sample, the amount of patients who've spoken to me who other people would have found, or at least if you categorize groups of people, which I've had in the past from other healthcare professionals, to say, no, that group of people will not talk to you about their fertility problems, actually they do. So I do think it's a bit of both. I think on the whole, people don't openly talk about it. I think it's changing, but I do think if you give people the right space to be able to do that, then they will be a lot more forthcoming than you actually think they would be.
And you're obviously someone who's very good at putting people at ease, Stuart. What advice would you give for people who are in kind of patient-facing roles and who have to try and put patients at ease in a quite a stressful or quite emotionally fraught situation?
It's very difficult. I think for me, when I bring up patient-focused care, I really do dislike treating everybody exactly the same. And that's not to take away equality, diversity at all, by the way, before anyone thinks I'm doing anything a little bit rogue out there. But I do think each person that walks through that door has an expectation, has their own anxieties, has a story that nobody's actually listened to, possibly, on their journey through your service. And the last thing you want to do is treat them like a donation service. So for me, having that time for them, giving them the space to ask questions, I think preparing them adequately for the road ahead if you can, and then signposting if you spot something. But I think part of the problem is recognizing, and scientists, I think, we're kind of told, or at least the impression we get is that we shouldn't get involved in the patient's overall health. We shouldn't think about how we're going to treat and support them through that journey. And that's absolutely the wrong way to be dealing with this. I think we should see ourselves as vital in that patient's journey, and if all we can do is listen and signpost, then that's going to mean a huge difference to that person. So I think just giving them the space, letting them talk, if you can help them, obviously if you can't, being able to direct them to sources that might be able to help, and just giving them the room to breathe.
Brilliant. And do you think, I've been hearing a lot about kind of patient stories recently, Stuart. I mean, is that something that you think traditionally the biomedical scientist, and it's obviously different in different specialisms, hasn't been kind of directly interacting with the patient? Do you think patient stories and kind of the patient journey can have an impact on biomedical scientists, even if they're not in a patient-facing role?
Absolutely. I think one of the biggest things that I think we are all still missing, and people can correct me absolutely on this, but I got a huge amount of understanding from things around me. One, again, just because I had this push to really look after the person, but my husband's a nurse, and actually only then by spending that time with him and discussing how little we actually know about what goes on in those patients' journeys at the end, at the beginning, through the whole thing. It really did put things in a different perspective for me, and made me realise how much none of the other healthcare professionals, including biomedical scientists, really understand what's going on with that person. So I definitely think, each patient has their own story, but I do think it's vital in hearing them, maybe getting them involved when you're making changes to your service, when you're looking at your material that you're going to provide them, but really bringing them in to get their comments, and trying to use them instead of, and hopefully not every service is like this, but if you do a user survey, do you involve your patients, and do you actually do anything with what they're telling you, or are you just looking at the overall outcome? 80% satisfaction, absolutely great, but what are they actually telling you within there, and can you listen to that and develop your service to actually cater it for that patient that might be telling you something in a very indirect way?
Brilliant. Very, very, very good advice there. And can you talk us through, is there such a thing as a typical day in your role, Stuart, or is it always massively varied?
Okay, so it's a bit of a difficult one. My role has changed quite significantly recently, but I think even now I still get in the lab, I still get that lab coat on, and I do the diagnostic samples, and supporting colleagues. I think every day is very different. I mean, we currently at Manchester we do the patient consultations for people who are going to hopefully preserve their gametes. So we'll talk to them, we'll get their consent forms filled in. And I think we really need to look at those services, because actually it's one of the most fulfilling parts of my role at the moment. Every patient is completely different in how they've reached the stage. You're vital in that part of their story as it is at the moment. And that can change dramatically, from emotions to what's happened to them to what could happen to them. You could be the bearer of another set of bad news for that patient. But that in itself can change from day to day. The diagnostic samples, I think we really do sell that short as well. I'm a firm believer in actually looking at the sample, and I know that sounds ridiculous. I'm sure anyone who does blood films or microbiology can really appreciate this, but the sample and their clinical history is telling you another chapter in their book, so to speak, and I think we really need to be looking at that. And actually every sample can be very exciting, maybe not if everything's normal parameters, but that's what we want at the end of the day. But every single sample is different, every patient's got a different health background that you can use to interpret those samples. Obviously, biomedical scientists and clinical scientists were heavily involved in the quality management side, which, by God, it's a lot, isn't it, everybody? But, it's vital in what we do. And then anything can crop up, let's be honest. So I think it is really very varied. But again, it's all hands on deck with andrology. It's one of the things that I'm quite proud of in working in this area is you deal with patients, you don't know what's coming through the door, everyone's involved from start to finish. And I think that's a really good thing to have in a team.
Oh, agreed completely. And for people who aren't familiar with andrology, or maybe don't know the exact functions and how it works, can you talk us through, say, the diagnostic semen analysis process? How does that, from the moment someone comes in and needs to provide a sample, what happens, Stuart? What's the process?
Okay, so in general, I'll tell you what the ideal situation is, I think, because there'll be plenty of places that are restricted with either premises or what they've had before. But I'll tell you what I think the ideal situation is. So a patient should come in, they should have had some information that tells them what their test is for and what they should expect when they come through the doors. Now, they're not going to know. No piece of paper is going to warn them for what they're going to be doing on site. And this is the other thing I need to stress is there's been so many jokes from people about what these poor blokes are doing. And, I think sometimes people who work in the area are guilty of it themselves. But actually, we do absolutely care about what happens to them. It's not an easy thing for these blokes to come through those doors and do what you're asking them to do in an unfamiliar place, on a hospital premises quite often. And even if they're not, you're expecting them to race through traffic to get it to you within 50 minutes of production. I think we need to take our hats off to these poor chaps who are coming through the doors. But once they're there, really they should be escorted to the room that they're going to produce their sample, and they should be talked through the process with somebody. That just gives them the opportunity to ask any questions. And I think that's where you sometimes can pick up on people who are hyper anxious, who may need longer, who may need to be asked if there's anything else that's on their mind. I do, as you said, study psychosexual medicine. So for me, these kind of feelings that you get from patients before, during and after any consultation are vital in understanding how they're feeling and thinking. You hopefully have put across to them what they need to do, leave them to it. When they have finished, in an ideal world, you should go in, read through any information they've given you. So I think that most patients should have a small health questionnaire that should ask them a little bit more than whether their sample's complete. I think you need to know what medications they're on, what surgeries they've had in the past, particular things that are relevant like recreational drugs. Then you can that opens up the door to ask them some more questions, to confirm things. And then you should be telling them what happens next, what's going to happen next on their journey. Hopefully they're okay and you send them on their way. Then the clock starts ticking. We have to look at that sample pretty damn quick. So we have about 60 minutes is the cutoff to assess the initial macroscopic checks, so things like viscosity, volume, pH, and then also motility. At that stage, you might need to prep the sample for vitality staining, which detects whether sperm are dead or alive, depending on the motility, so the movement of sperm. And then you go through a set of activities to assess the concentration, the morphology, non-sperm cells, the concentration and differentiation of those. And then hopefully that sample gets reported with advice for the user, including whether or not that patient should have a repeat or whether they should be referred on to other services. And then for me, I think the important thing as well is to have somebody there in the service who can answer questions and explain things to the users, whether that be GPs or patients once they've got their results. I think you need to have those people available who can talk to the patient if they've got any more queries. But that's pretty much it in a very rapid nutshell, because I could probably talk a lot about this.
You mentioned psychosexual medicine back there, Stuart. That's a term I'm aware of, but a subject I know nothing about. What is that and how does it play into your role?
So I don't know if anyone else has ever noticed this when it comes to andrology, but one of the biggest things I had coming through the doors was patients who they would say to you, they just can't do it. Now that can be incidental. It could be the environment. But sometimes you'd get men start to open up about difficulties because they can't get an erection anymore because of the stress, the anxiety of trying to get this child, having to have sex 3 times regimented per week, going through waiting for the right time in his partner's cycle, and then, going at it like rabbits, as some of them would term it. But also I had a lot of blokes who'd tell you that it won't take them long, so they were alluding to premature ejaculation. You had some men who would have delayed ejaculation, and some that would have intermittent retrograde. So what I found a massively useful tool was to look at this not only from the medical side, because I think the trouble is we tend to throw medications at patients. But just listening to some of the stories, you could tell that there was a psychological element. Nothing was a problem before a certain point. And that might have been because of the fertility or trying for a child. Sometimes these problems had happened well before they walked through the door. So for me, it was important to listen to them and to see whether or not there was anything you could do, you could pull out to support these patients in their journey. As I say, it's not always just having the child that's going to fix problems for these couples. So what I started to do is I did an introductory course with the Institute of Psychosexual Medicine, where they look at basically mind and body, the relationship between things. I mean, it is what it says. The sexual problems, could they be coming from a psychological place? Could it be influenced by what's happened to that person in the past? I've had patients who've said that somebody's just said a bad thing about their anatomy, shall we say, and that's made them really struggle with erections. They've had an arranged marriage and he's never been able to make his partner happy. Now they're coming along for fertility treatments, yet nobody's asked the question about whether or not he can get and maintain an erection. So that's why I found it it was a key player in how I would speak to these people. And I won't lie, even though it's andrology and that's my speciality, I have picked up on couples that have attended where his partner, the female in that relationship, has been under more anguish, more anxiety than he has. And that's really, really helped support that couple go further, have the support that they needed, and then come back to trying to go through this process, because it's not an easy process going through fertility issues as a couple. The woman goes through a huge amount of tests and then surgical interventions for a male-based infertility factor. Let's make sure we've done it right. Let's go back. Let's stop the clock a little bit, as long as you've got that time, and try and support them a little bit more than just throwing a bit of cream or some Viagra at these poor couples.
Brilliant. And I mean, obviously a lot of people are coming in for fertility. You must also have cryopreservation for cancer patients. Is that a big part of the job, or is that a smaller element?
Oh gosh, no. So at the moment, that forms a massive part. So it doesn't sound like much. At the moment, we have about 3 patients a day. But if you think about that in a different way, that's 3 patients who are possibly going on for treatment that may or may not help cure a disease. And what you're doing is you're supporting them through that little part of their massive journey. It can take all morning and leach into the afternoon, but actually to me this is one of the biggest areas. As I say, 3 patients a day doesn't sound much, but these are the patients that also need a huge chunk of our time. So as I said before, we consult with them, we go through the consent forms, we allow them to ask any questions, we allow them the time to sit back and take a deep breath, because at the end of the day, some of these patients might have only had a diagnosis a couple of days ago, and there they are in front of you being asked to produce a sample that may or may not determine whether or not they have kids in the future. And even if they do produce a sample and they do store it, there are no guarantees for them. So we're there to be the people who we quite clearly tell them we're not doctors, we're here to support them, we'll answer the questions we can. But I do think it's a fundamental part of our role, and it's actually a huge part of our role. I think if anyone has had experience of these patients, would hopefully understand. So yeah, it takes a long time, but I think it's a absolutely vital part of what we do as andrologists.
Brilliant. And I've been so caught up in talking to you, I've taken my eye off Twitter, but we've had some questions that have come in, Stuart. So first off, a question from Marie Kirby. Could we go back to equality and diversity, and how do we safeguard those patients where English isn't their first language? I do worry how to make sure they understand what is happening for them.
Yeah, do you know, it's a very, very interesting thing. I think everybody who works with patients will understand it can be a very difficult subject to navigate, and also very easy one to take a very rapid way out. And for example, I know with our trust, there is a definite rule that you don't use patients' family and friends as an interpreter. And I think that's one of the first key things that I would say, is that actually, yes, it would be quick. Yes, it would be easy. And yes, you might go behind from getting in an interpreter, whether that's telephone or face-to-face. But that is the only way, if you get that patient with an interpreter, that you can get the information across to them and be sure that what's being relayed back to you is actually appropriate. Because at the end of the day, you want informed consent for anything that you're doing, and you need to make sure that they understand the implications of what's happening. So that would be what I'd say with the non-English speaking patients that you get. Do use your trust-approved interpretation services. I think they're vital with these patients.
Brilliant. And we've got a comment from Carl as well. Carl, a regular listener who I recognise. Hello, Carl. He says, I totally agree. You get a narrative of the patient case. It's important to understand the patient story. So sorry I'm a bit late on picking that one up, Carl, but that's going back to the importance of patient stories.
Oh, gosh, absolutely. And I think this is one thing that whenever I've worked somewhere, I make it sound like I've been around the block. I worked at a few places, but I did stay in Birmingham for some time. But I think this is one thing that's really important in what we do. I think we can get so bogged down with the amount of patients or samples coming through our service. Each one of them deserves somebody having a look and thinking, what is this telling me? We've just implemented a little bit more of a health-based questionnaire system in Manchester, and all of it builds into the outcome for that person. So I think it's one of the vital things. You definitely need to have a background or a narrative to what's going on under your microscope.
And cryogenic testing, is that something that comes up a lot in your group?
What are we talking about?
Cryogenic testing for the right patient.
You'll have to be a bit more specific. I've not heard a term like that, if I'm honest with you.
It's a cytogenic.
Got you.
I dreadfully scribbled down notes because I took some notes.
I thought I was going a bit crazy then. You're just trying to test me. It'd have been a bit embarrassing if I'd have made something up about that. No.
It's more embarrassing that I can't read my own writing.
Absolutely. Okay, so cytogenetics is one of those areas I think most andrologists are aware of. Well, I hope they are, but they tend to get a little bit overprotective in urology or fertility consultations about cytogenetic testing. But one of the things I found when I was looking after our patients is I'd often see them if they had an initial azoospermic results where there's no sperm in their semen. What I would do is get a confirmation test, and also I'd spend some time to counsel them in cytogenetics. So basically some basic genetic testing. If you're ever going to do any test, and I hope everyone agrees with me on this, you should make sure that the patient understands what test you're having, that you're going to be requesting, and what the implications are for those tests. And I only slightly laugh when I say that, because the amount of times I've been to my GP, and no offence GPs out there, but the amount of times I've gone there and they've just gone, we'll get some tests done. And I've been like, what tests are you getting done? You know, and I think that's the important thing. So for me, cytogenetics should be done for certain patients, particularly those patients who've got no sperm in their semen. And one of the tests that gets missed out is something called Y chromosome microdeletions, or IBMS testing, which can actually be incredibly clinically relevant for those patients. One, because it can determine whether you'll find sperm in their testicle if you were to go in through surgical sperm retrieval. Equally, if there was a child born and that child was male and they had AZF microdeletion, that gets passed on from father to son. So there are implications even for, and if you could see my fingers, there'll be, you know, little brackets going on here. But even for a little test, I do think we need to make sure that they're given the information for it. But the other test is karyotyping, where we check that they have the right number of chromosomes. And also we look at CFTR mutations in certain patients, particularly those patients that might have a particular sample which is showing low volume, low pH, and no sperm. Those patients would benefit from CFTR mutation testing as well. But it's just about making sure that you're getting the right patient, you're capturing it, you're getting it done, because these tests take time. You know, genetics laboratories are getting busier and busier. If there's anyone here who works in genetics, I'm sure you can confirm. And it's a highly needed service at the moment, and it's only going to get more in demand. So these tests take time, and with time isn't always a factor for some of these patients. So I think intervening, getting the history of a patient and actually counselling and getting the tests taken and done for them, it is pretty vital in their pathway.
Is it a tough, stressful job, Stuart? It sounds like there are going to be lots of highs and lows, and lots of people who are eventually very happy, and lots of people who are a bit heartbroken.
Yeah, I think the trouble is with andrology is that you are a small blip in that patient's journey. You know, often it's an inconvenience for those patients who've got absolutely huge numbers of sperm, or they've had a child before. You're just an inconvenience, and therefore sometimes I think the problem is you don't always get the happy or negative outcome. And you can look at that both ways, can't you, really? That there's a benefit in not knowing. But ultimately, what we do when we're seeing these cancer patients, when we do talk to the patients about the issues they're having, obviously it can have an impact emotionally and psychologically on a lot of people. What I would say is, and a colleague of mine who works in Manchester said, you know, take the time to talk about anything that's affecting you. Obviously, we need to make sure there's patient confidentiality that's in place, and we can't breach those. But you can offset some of your emotional considerations or what may have upset you, and take what you're doing and be proud of it. And I think as biomedical scientists and clinical scientists, what you're doing is often overlooked. And I think that's quite clear with the strikes and everything. You know, these scientists that are absolutely vital in patient care and treatment are very much overlooked, but take pride in what you're doing. Even if it's a negative outcome for that patient that you're being part of their journey with, you're doing something that's going to help them in one way or another. And I think we need to start taking a hold of what we do and being proud of the professions that we're in.
Oh, completely. I think that's the case across the board for biomedical science. I think you're right.
Absolutely.
And I mean, when we're talking about the psychosexual medicine, it seems like there's quite a tangible link between mental health and your job. I mean, how closely linked are you to mental health services? Do you work closely together, or is there a kind of a big separation? Is that a tricky leap?
I think there's a massive separation anyway of mental health services. I think we're lucky because we are in a unit which has a HFEA license, And therefore, we have a counsellor that's from Beaker, which I think is the British Fertility. No, the British Society. Oh, I can't remember now, but it's the society that supports counsellors who are trained for infertility. It will come to me. I'm so sorry. But basically, we have access to counsellors for patients. What I would say, though, I think mental health overall. So yes, in our job, we do have access. We can ask patients, we can give them the information, they can self-refer. I think mental health overall is still not taken as seriously as it should be. I think I was looking up earlier on about men's mental health. You know, we form part, 75% of suicides are still male, and I know the number's increasing for women, but it's been a huge chunk of suicides has been men for a very long time. The only information you ever get out there is that men aren't referred to these services because they don't present as needing the help. And I do agree with that in a large part. There's a lot of things that have barriers, but I don't necessarily think that we provide the services to recognise and offer the support to these patients. So we're quite lucky. But actually, do people consider those patients? Has anybody heard a patient say how difficult things are for them and not asked if they want the number for mental health services? So I think there's things that we can do. I know in other areas such as A&E, you know, when they're looking at people going through the doors there that might have self-harmed, that they probably have better access to crisis units and psychologists there. But I do think it's something that's lacking in pathology in general. I do think that we need to start thinking a little bit more, especially if you have patient-facing services, about how you can support their access and not just say, well, you know, I think I said this in the article that was published in the Gazette. Basically, we tend to say, well, they need to help themselves. And we don't think like that for a lot of other health conditions. And we try our best to give them the access and to make access easier. And I think that's how we need to start approaching mental health services, particularly in relation to men, but across the board.
Brilliant. And we've had a couple more comments come in on Twitter for you here. We've got one from Sherry Beckett. Hello there, Sherry, the legendary founder of the IBMS chat. So Sherry says, hats off to you, Stuart. Real patient-centered care in every element of what you're sharing with us tonight. Every sample represents a patient and every patient matters, which I'm sure you would agree with.
Absolutely, 100%.
And then we have a question from Marie who says, has anyone else seen the increase post-pandemic? It feels like we're really struggling sometimes with patients compared to available appointments. Is that something that's come up for you at all, Stuart?
I don't think it has now, but especially in my previous service, because that's where we were hit hard. They shut down most of the andrology clinics across the board. And incidentally, they then also, NHS England said that patients couldn't even have tests from GPs that were relating to fertility. But I think once we were back open, we did we were pretty lucky in that our trust supported us getting those patients triaged as we thought they needed to be, and actually seen in a relatively quick time frame. Now, that obviously may not be the case for a lot of services. And again, at the place I'm at currently, we have a huge number of appointments that are filling up constantly. But again, it depends on your services, your staffing. Have they got appropriate staff to be able to support the increase in workload? It's no surprise that people are struggling because there was a huge amount of time taken off them. But what I would ask is that these samples are no less important to the couples that are going through this or who've been waiting. When I was doing these sexual dysfunction clinics, some of these patients were waiting 2 years. That's really, really not on. So what I would say is the trust need to look at these as equal to other people going through difficulties and try to support the staff in getting those patients seen as quickly as possible. Obviously, it's not the same as the 2-week wait pathway. I would never suggest it is. But from the patient perspective, who are struggling and may have been struggling for some time before that referrals come in, I think we need to do everything we can to get these patients seen. But it's very difficult. Resources are sparse in the NHS, I think across the board, and particularly in pathology. I still think that we're relatively underfunded and supported, and I really do think we need a bit of a boost to support us with those services that rely on us, regardless of andrology. As I've said before, a lot of different services rely on diagnostics, and we need the investment.
Brilliant. And if anyone else who is listening wants to just post any comments on Twitter for us, that if you're noticing an increase or a decrease, then they don't have to just be questions for Stuart. If you just want to join in the debate like that, then please pop it up there and we'll read out your comments. We've also got a question from the IBMS South East Wales branch, who have asked, BACP, British Association for Counselling and Psychotherapy?
Okay, yeah.
So I think that's the extent of that question.
Okay.
Is domestic abuse a big question? Sorry, a big issue, Stuart? I mean, we always think of domestic abuse being something that always traditionally, and maybe naively, thought of as something that always just happens to women. But do you find many men involved in your service that have suffered domestic abuse? Is that something you find out much?
So I've been relatively lucky, and I say that because obviously it's a horrendous thing that anybody goes through with domestic abuse. But relatively lucky, there's been few and far between cases. But what I would say is the data is out there to say that, I'm pretty proactive in this, in that there's a third of all victims of domestic abuse are male. It's a predominant female to male when it comes to those third of people. So 98% of those men that come forward with domestic abuse, it's generally perpetrated by a female. And I still think we do not take it seriously. And I think that goes from funding from the government right through to how we tackle it in hospitals. And just a little bit of a dark past is that when people have domestic abuse services, yes, there's a different degree of potential endpoint. More women are murdered by their partner through domestic abuse. I think that the data says it was slightly greater than 70, and then it was about 12 to 15 for men. So there is a big difference in the murder. One life is too much, if you ask me. But what I would say is that we do need to start treating it and looking at this from an all victim approach rather than just the gendered perspective. If we concentrate on the gender perspective, and some places only provide domestic abuse advocates for women, the NHS is predominantly female workplace based, but that then puts the men in the minority, and any other category of person in minority would have the support and be looked at and have the mechanism to speak up if they feel that they can't. And that isn't really happening with domestic abuse. Now, we do see patients from both sides, the male and female, where it definitely, your instincts would say, is there a safeguarding concern here? Safeguarding obviously encompasses domestic abuse. And what I would suggest is that people have posters in their room where men can contact male-specific organisations. You do need a bit of training to be able to deal with these patients, but if all you can do is signpost them, I think you should. There's definitely a trend with coercion and control instead of outright violence when it comes to male victims of domestic abuse, and this can filter into the world of fertility. But luckily, it's been few and far between. But I definitely think it needs a lot more work. You need to make sure that the data is being collected appropriately. As I say, if you've got a trust that doesn't actually deal with the men, the data is always going to be skewed. But if you're going to do something, the one thing I would suggest is make sure that your referral service, if you can, is local. There are little local projects popping up all over the country, and they don't treat men as perpetrators, which some of the abuse helplines are well known for, shall we say. So what I would say is if you can find a local service that the men have easy access to and ask their permission if they've got information that you can provide for these chaps, then absolutely great. Don't neglect the woman, because obviously men attend with their partners, and she may be outside in the waiting room while he's inside, and she could be the victim. So just look at it from both angles and try to support domestic abuse victims overall is my suggestion.
And I can imagine with kind of traditional gender norms and notions of masculinity that men of particular ages can find it incredibly hard to come forward if they're suffering some kind of abuse, even if it's not violent, if it's coercive. I mean, is that something that you think is going to change? Because we're hopefully entering an era where these kind of notions of gender stereotype and role are kind of the boundaries are blurring a bit, and everyone's not being quite so siloed about everything. Is there hope that in the future things like men coming forward for domestic abuse will be far less of an issue than it is at the moment?
It depends. If I'm going to be honest, I think the barriers are slightly different. A lot of them cross over. There is not the support for men at the moment. So there were over 360,000 spaces for women in the UK, but only just under 400 for men. So when you look at the 1 in 3 victims will be men, but there's less than that as a representative. What is the point in coming forward if the support isn't there? There's very, very few specific spaces for men to actually go to. And then depending on if they've got children or their own personal situation, it can be difficult. Now, I do agree, we're being encouraged to talk more. And as you say, the gender norms, I'm not necessarily convinced that gender norms are always as toxic and harmful as we perceive them to be. I just think that we need to navigate a never-changing world and accommodate all types of people, regardless of whether they're stuck in the 1960s or whether or not they're, modern day era person. I think we need to consider every individual person and not expect them to necessarily come forward, but to provide them with as much help as we can, even if that's just a listening ear or direction to somewhere else. The one thing I will say, because of COVID, I mean, most helplines seeing over a 70% increase in men calling for support. If nothing else, there are advice lines like Mankind Initiative that can support people. I know there's one local in Manchester. The LGBT community have got have got their own access to domestic abuse, and obviously you've got Women's Aid for Women and Refuge. So there's plenty of advice lines. So if nothing else, at least pop those numbers around there.
That's a really good, well-structured answer there, Stuart. Thank you very much. We've had a follow-up from the IBMS South East Wales branch, who've said re BACP. It was a comment in relation to trained fertility counsellors.
Oh, it was BCA that I was suggesting. So infertility counselling, British Infertility Counselling Association was what I was thinking of.
Brilliant. And thank you for clearing that up, though, IBMS South East Wales. And we've got another question from Sherry, who said, how would you sell your specialism to those who are looking to come into the profession? Why do you love your job, and why should a prospective biomedical or clinical scientist choose andrology?
For me, it's the patient side of it. Now, I know you can do a lot of different healthcare careers, but I think we deal with patients on a daily basis, even if it is a service that's limited by taking that sample from a patient in specimen reception, you're still dealing with that patient. I think that interaction makes it absolutely unique in many ways. As I said, from my perspective, supporting patients from not only an infertility, but a sexual dysfunction, and also helping them get through any difficulties they've got is quite unique for a scientist. I'd also say that, as I mentioned before, every day is different, and we are privileged to be part of any of these patients' journeys going through our services. It could be as simple as a normal patient sample, right through to these patients that we're looking after for cryopreservation. But I'd say that, we are trying to support them. It is a big part to that person or that couple that are going through the service. And no day is absolutely the same. I failed to see any time in the past, oh gosh, how many years? I don't want to even count, but there has absolutely not been 2 days that have been the same. Yes, it's busy. Yes, it can be very stressful. There's time limitations for the tests that we've got to do. But I think at the end of the day, everybody who works in andrology has the same passion for that patient, the couple, and you get to use your scientific skills, your interpretation skills, and hopefully that will develop for andrology moving forward. We're very young as a career. We're slowly getting more recognition. Obviously, the STPs, and I know the IBMS are working to try and support future qualifications for andrologists. So it's a very young and exciting area. So hopefully things will only get better and develop. And I must say, if you're privileged enough to work with embryologists, you can support embryology teams in the patient treatment side of things as well. So there's a whole heap of things that can feed into it.
Is andrology set to grow over the coming years, Stuart, or is it kind of at its set level now, do you think?
Well, I hope not, because I'm not retiring just yet, and I don't really want to set everything down and say this is it. I think it's going to grow. I mean, generally, you haven't found many andrologists go past a certain point, but I do think there is absolute scope for it. I think I said this at IBMS Congress last year. I think our strengths come in our clinical side, even biomedical scientists, and I don't mean this in a patronising way. I do think biomedical scientists sell themselves short quite often. You can be involved in the clinical aspects of that patient care. Codes of practice are no different, really, apart from a few key phrases. But we can definitely strengthen and support the clinical aspects a lot more. There's further training, and obviously biomedical scientists can go on to do the HSST if they want to. So I think there is development, and I think with ever increasing scientific advances such as genetics, I think we're going to see an evolving career within andrology. Who knows where exactly? I'd like to see it go in a certain direction myself, but I am a little bit biased with our patients. And I do think that we have the ability to support them in similar roles to other healthcare professionals, and we can support the NHS's difficulties with workforce if people utilise our skills appropriately. But I definitely think it's got a long way to go yet.
That is good to hear. And just to loop back to some of the things causing fertility issues in men, Stuart, when we were emailing previously, you mentioned anabolic steroids.
Oh gosh, yes.
I'm assuming, I know nothing about these. Is that the ones where bodybuilders take them to kind of bulk themselves up?
Yes. What I'd like to say is, yes, I generally tend to sell this subject as anabolic steroids. But what I would say, any testosterone type of drug, shall we say, can have a negative consequence to men's fertility. It's one of those areas that you hear of, you think of, until you start getting those patients come through your doors who tend to know a huge amount more about endocrinology than you ever thought you would. I started to dig into it, and actually we opened up a hugely interesting, complex and fascinating world for me. So the difficulty is with steroids is, yes, people think you take some more testosterone. Most of the people, as you've said, Rob, and it's not I'm not picking on what you said, but most people associate it with bodybuilders. The truth is, a lot of patients will start because of that, because they want to get bigger. Sometimes it comes from a place which is down to body difficulties or body dysmorphia disorder. It's not necessarily always because somebody wants to pose in front of a camera and look the biggest they've ever been. But they do take these, and a lot of them are very clued up. They meet people in the gym who have a huge amount of access to different types of drugs. I've had all sorts of things that patients have taken and got their hands on, including growth hormones. We've got Clomid that often is only prescribed to the female for ovulation induction, and very rarely is it given for spermatogenesis induction treatment. But these patients often don't realise what they're taking. So I started to talk more to these patients, learn a bit more about it, and actually realise that there's a huge amount more that needs to be discussed with them. So I went away from just saying, well, if you take this, it's going to stop your sperm production naturally because your body thinks you've had enough testosterone. And actually, I started to gear it to, okay, so tell me what you take. How do you take it? Is it oral? Is it injection? How do you take it? What type of cycle do you have? Do you have any post-cycle therapy? Have you got any children before? How did you conceive those? And also, why do you take them? And pulled away from saying, well, if you don't stop them, you won't have a child, because that's to nobody. If he struggles and he uses it because it gives him focus, or it makes him less tired, or it increases his libido, yes, it could be holding hypogonadism of some sort, but equally, what you want is that patient to understand everything about what they're taking. At the end of the day, your job is to say, there's no sperm in your semen. It is likely down to the use of X, Y, or Z. And you can advise what somebody should do next. But that's not going to take away the reasons that person's on it. It's like anything else. You can't just stop it just because you are going to tell them that they can't have a child. And I think the other thing that I found is that some of them didn't know the impact it had on overall health. So some of them I'd end up requesting liver function tests because they were taking pills. And that increases the damage to the liver. And none of them knew it, or they'd stopped taking it, and they still had a huge amount of bilirubin that was found, most likely due to the steroids. And I think this is it. You kind of need to say, well, this is what you're doing. This is the information you've got. It is likely to affect your fertility, but here's the information that you can go and find out about it. But it's very unlikely you're going to have a child if you continue using them. And then that can open up other conversations. As I say, some of them have needed access to services for clean needles. If they're using dirty needles, is it your job to tell them to stop using the testosterone, or that they need to make sure that they're not using dirty needles whilst they're on that journey to it? So it's been a fascinating, complicated, and it has made me question, your role as a scientist is relatively limited, but it's within your scope of practice. And that's developed over time with these patients. But again, I've had some blokes who don't do it because they want to be huge. They do it because they hate themselves. Now, that is a complicated psychological issue for that person, and you telling them to stop testosterone to have a child is not going to work. So that's just a bit of a flavour of my experience.
No, I really admire that approach, Stuart. I think it's brilliant that you're not just going for that blunt hammer of, stop doing this or you won't have kids. But, we're going back to the patient stories again and treating every patient as an individual. And, I think it's great that you take that nuanced approach and go into everyone's story and treat them as individuals. I think that's really a great thing to do.
Cheers.
We've had another question has come in from Marie Kirby, who says, how do you feel about fertility services running through gynecology? I know that because of patient lists, men are often listed, and then sending results sending results requires more care and effort than for female tests.
Yeah, sorry. So basically, how do I feel like it running under gynecology, I think, is the general gist of that one. There's a reason it does exist under there. And as I said earlier, the female, if it's a heterosexual couple, male and female, the female will go through a huge amount of tests and be subject to treatment that the man won't. So I do understand why fertility falls under there. If I put my hand on my heart, I would say fertility, in specific for andrology, should be under urology. But that comes from the fact that in reality, if there is azoospermia, yes, there's lots of gynecologists that can look after these patients, but really they should be referring them on to urology, andrology consultants who can support that patient. The problem is that they're not often linked very well. So what I would say is that the best way forward would be to have them side by side, urology and gynecology, splitting the patient off and joining them back together when things have been looked at. And again, as I've said before, sometimes having that patient on their own is great for both sides of the issue. But that's how I feel. I think it sits much nicer under urology.
Fantastic. I think we're just about at the end of our hour, so we're going to have to wrap things up soon. But just a reminder to everyone that Men's Health Week is on I think it's the 12th to the 18th of June. And we've got another very special day tomorrow. So tomorrow, of course, is Biomedical Science Day. Stuart, to put you on the spot, are you doing anything, or is your trust doing anything for Biomedical Science Day at all this year? Or is it a quiet one down the way?
Well, I'm off this week, so unfortunately, very badly timed because normally we force ourselves onto somebody somewhere, but no, unfortunately, the staffing has its own restrictions, and we have a huge clinic booked in for most of the staff that are there, so they're unable to carry out anything. But I do know that pathology across the way are pretty active when it comes to Biomedical Science Day, so it's a bit sad that I won't be doing anything. But I do obviously wish everybody who is promoting it. I'll be on Twitter, don't you worry, making sure that our 2 pennies worth is flung out there and representing us. So sadly, I will not be, but usually I do. So bad planning on my behalf.
Well, more importantly, thank you so much for joining us on your week off, Stuart. And you should be putting your feet up and having a nice time. But we really appreciate you coming on here. And I think you've put across some very empathetic points and some very caring points. And yeah, I'm sure everyone who's listening would join me in saying that I think you've been a fantastic guest and you've got some really insightful points and you know an incredible amount. So thank you so much for joining us tonight.
Cheers. Thanks for the opportunity. One more thing I would say is if anyone wants to promote men's health, do think about it in their areas. There's also an International Men's Day. I know not a lot of people are into international days, but they're the ideal opportunities to get information, get some leaflets, get some posters out there as well. And good luck to anybody who's hosting an event tomorrow. I think every scientist really needs a bit more appreciation. We do a huge amount for these patients, and hats off to everyone churning out those results with the biggest passion behind them.
Oh, completely. Hopefully this will be the biggest Biomedical Science Day yet. And if anyone's got any questions for Stuart that they either didn't get round to asking or they didn't want to ask in front of an audience or anything, if you just send them to me on Twitter, I'll make sure we get them over to Stuart and we get you some answers. And yeah, we'll get that sorted for you. But yeah, thank you everyone again. I hope those who are taking part in activities tomorrow have a great Biomedical Science Day. And yeah, thank you so much again, Stuart, and everyone else for joining.
Thanks so much for listening and hope you enjoyed the podcast. If you did, why not tune in live to the next IBMS chat at 8 PM on the first Wednesday of every month on the IBMS Twitter feed, where you can join in live and ask the speakers questions. Just keep an eye on the IBMS social media feeds for details of the next session. Thanks again.